Today's session. My name is Rafael Haciski, and I'm the Vice President of Healthcare at Johnson, Kendall Johnson. We are very proud to partner with Lutheran Services in America and are very appreciative for all of the work that they've done to help facilitate this session today. Johnson, Kendall Johnson, just so you know, is one of the premier insurance brokerages in the United States, focusing exclusively in human services and senior living clients. Our associates work with folks who address the unique issues and needs with service-oriented, value-driven, and affordable risk management and insurance solutions. Today, we actually have the true rock stars of JKJ, John Kiefner and Cullen Wise, Vice President of Risk Control Services at JKJ. And today they're going to be explaining the four main components of an OSHA compliant respiratory program as they pertain to COVID-19 protection in the healthcare setting, and what you as organizations can do to ensure the continued compliance. They'll also discuss recent OSHA citations in healthcare, how and when to record COVID-19 cases on the OSHA 300 log, and how to navigate OSHA's record keeping and reporting homepage. As always, we will have time for some Q&A at the end of the presentation. So feel free to use the chat feature on the right-hand side and enter your questions into the box, and we will have them tossed up for John and Cullen at the end of their presentation. And without further ado, I will pass it over to Mr. John Kiefner.
Thank you, Rafael. My name is John Kiefner. I've been with Johnson, Kendall & Johnson now for about 20 years in the Safety and Risk Control Department. I have Cullen Wise with me today, and the two of us are going to handle the question, are you OSHA COVID-19 compliant? And we'll jump right into the agenda here. We're going to first talk about the National Emphasis Program on Coronavirus Disease, which was released in March of 2021. Cullen is going to get into OSHA compliance in regards to the Respiratory Protection Program, which I'm sure many of you are in the thick of right now or have been over the past few months. We'll go through some recent OSHA activity within our healthcare clients. The National Emphasis Program, to the best of my knowledge, has not been activated or released to the extent where our clients are seeing any activity yet. However, since the summer of 2020, we've seen a lot of OSHA activity among our clients when we've had complaints in regards to coronavirus and when we've had unfortunate employee fatalities. So we're going to go through the different citations that have been issued since early 2020. We're then going to get into the OSHA record keeping of COVID-19 cases on the OSHA 300 log. I'm sure many of you have been through this over and over the past 6-8 months, but I think it's important just to clarify some things that keep coming up. And then lastly, we're going to go onto OSHA's web page for record keeping and reporting and help you navigate and fully understand the reporting requirements. So let's first talk about the National Emphasis Program. On March 12th, 2021, OSHA announced the NEP on coronavirus disease and stated that it was going to focus on the protection of high-risk workers from COVID-19, which does include healthcare, manufacturing, warehousing, construction, and some other select industries. Now, when we wrap this up at the end of the session, you will be receiving some resources, some links. You'll be getting the link to the National Emphasis Program so you can see the details and some of the items that we're going through today straight from OSHA's webpage. The National Emphasis Program will also include follow-up visits on work sites that were inspected in 2021, and 2020. Now we're going to get into the 6 required components of a respiratory protection program, because this is typically the #1 area of focus. Cullen?
Okay, thank you, John, and welcome everyone. We'll get into the respiratory protection program information in a moment, but I'd like to begin by talking about addressing hazards using what we call the hierarchy of hazard controls. As with any hazard, the use of personal protective equipment is always the last level of control you should consider. Engineering controls such as adequate ventilation and barriers should come first. Next, administrative controls like distancing, hand hygiene, health screening, and cleaning and disinfecting practices should be in place. And finally, if you can't avoid close contact with people known or suspected to have COVID, the use of PPE, including respiratory protection, is needed. It's important to document your evaluation of the circumstances in your facility and categorize employee risk of exposure, and then address the risk according to the hierarchy of controls that I mentioned. OSHA's publication, Guidance on Preparing Workplaces for COVID-19, defines risk categories and includes suggestions for each level of control. If you haven't already looked at this guide or conducted an overall risk assessment, I would strongly suggest you do. Your evaluation of risk should be the first step to determine if respiratory protection is appropriate and whether it's deemed as required to use or just offered for voluntary use by your employees. Okay, now moving on to respiratory protection. The goal of my information this afternoon is to allow everyone to gauge where you stand when it comes to compliance with OSHA's requirements. Whether you are starting from scratch or already have your program in place, after this session, you'll know the action items that you have to work on. Everything I'm going to review can be found within the OSHA Respiratory Protection Standard, which is 1910.134. Just do a search for OSHA 1910.134, and the first item that should come up will take you to the standard. For the purpose of today's discussion, we'll focus on the use of N95 filtering face piece for respirators. And notice that I did say respirator, as OSHA does consider them to be respirators, not simply masks. Okay, so let's look at the 6 required components of a respiratory protection program when the use of a N95 is mandatory. Number 1, a procedure for selecting respirators for use in the workplace. This is where your documented hazard evaluation is really important, as it's the basis for your overall respiratory protection program. Your procedure should detail how you conduct your evaluation, anticipated hazards, and the appropriate respiratory protection to be used. We suggest using OSHA and CDC guidance on COVID in healthcare settings and include these guidance references in your procedure. If you're not in a healthcare setting, OSHA and the CDC also have some additional guidance for other industries as well. Number 2, medical evaluations for all users of respirators must be completed before the use of the respirator. Appendix C of the OSHA Respiratory Protection Standard is a medical questionnaire that has to be completed by each user and then evaluated by a physician or other licensed healthcare professional. Depending on responses to questions, the physician or other licensed healthcare professional may order further medical evaluations of some employees. Number 3, initial and annual fit testing for all users of tight-fitting respirators, including the required use of N95 filtering face piece respirators. The purpose of the fit test is to verify the equipment can adequately protect the user and assure they can use the equipment properly. When fit testing, the user should be taught how to perform both a positive and negative pressure seal check. The seal checks are sort of a quick way to tell if the respirator is being worn properly and fits. Qualitative fit tests using either a bitter or a sweet solution are used for N95s. Due to an ongoing fit test supply shortage, OSHA continues to relax the enforcement requirement for annual fit tests, but initial fit tests before use are still being enforced. If you've already completed fit tests, that's great, but don't forget that on an ongoing basis, new hires who may join your organization should be required to have the fit testing and the medical evaluation completed before they use the equipment. In terms of compliance, what should you do if you can't find fit test supplies at all? Well, if that's the case, we suggest that at a minimum, you educate users on how to perform the seal checks and have them demonstrate the ability to do this and make documentation of this. Number 4, a procedure for proper use of respiratory protection during normal and foreseeable emergency use. For this requirement, you can utilize manufacturer instructions for the use of equipment to develop your procedure. Also in this step, I suggest stating the circumstances when a respirator use will be mandatory. Number 5, procedures and schedules for cleaning, disinfecting, storing, inspecting, repairing, discarding, and otherwise maintaining respirators. Again, use manufacturer guidelines for equipment to develop these procedures. The CDC has developed guidance on extended use and limited reuse of N95s that you can use to develop this procedure. Their information should help you define the maximum usable life of your equipment and when equipment should be discarded. This will be helpful if you're in a situation where you are trying to conserve a limited supply of N95s. And number 6, at least annually, you must train employees on the following: respiratory hazards to which they are potentially exposed, the proper use of respirators, including putting them on and removing them, any limitations on the use of equipment and the maintenance of the equipment, Here you essentially need to train users on all the required procedural elements mentioned in items 1, 4, and 5 earlier. For any strictly voluntary use of N95s, all you have to do is provide a copy of Appendix D from the OSHA Respiratory Protection Standard to all users. The appendix is called Information for Employees Using Respirators When Not Required Under the Standard, and then that's it. Nothing else is required, nothing else is necessary for any voluntary use of N95s in the workplace. Now, if this all sounds overwhelming, and I don't blame you if you feel a little overwhelmed, don't panic. There are a lot of resources available to help you with compliance, and we'll be sending out some of those resources afterwards, including CDC and OSHA guidance that are referred to, information on how to perform seal checks, and even some links to train you on performing fit tests. Okay, that wraps up my information on respiratory protection. Now I'll send it back over to John to address recent OSHA activity in the healthcare industry.
Thank you, Cullen. So these are some of the areas that we've had focus from OSHA with clients over the past 6-8 months. Respiratory protection, as Cullen just went through, has been number one. We've been seeing on average about a $13,000 citation per community that's visited if they lack in any of the following: the written program, the medical clearance for N95 use, the fit testing, the training, or the use of non-approved KN95s. So even if you get cited for 3 or 4 of those items, they typically will lump it under one citation, which has been averaging about $13,000. As you can see at the very top of the screen, when we put this PowerPoint together, OSHA had issued just shy of $4 million of COVID-related fines. That number is probably closer now to 6 or 7 million and is going to increase significantly over the next year. As you can see, number 2 is severe injury reporting, and those were about $9,000 per citation. And we won't get into all the details right now because I am going to take you through and navigate OSHA's webpage. But severe injury reporting is for fatalities, it's for hospitalization, loss of an eye, and we will get into the details in about 15 minutes when we get to that section. Number 3, OSHA record keeping has been about $5,000 per citation. And these incidents include the failure to report occurrences on the OSHA 300 log. And Cullen's going to get into, from a COVID perspective, what should go on the log and what's not needed to go on the log. Hazard communication was one that we weren't expecting, but we started seeing when OSHA asked about the cleaning chemicals that were being used as a result of COVID to sanitize. And that got them into looking at the hazard communication programs. They were looking for written programs. They were looking for safety data sheets on the new chemicals that were being brought into the community. And they were also looking at training on those chemicals. And those citations were averaging at about $7,000 each. Again, if 2 or 3 of the items that I just mentioned were lacking, they would typically lump it under one citation. And that led them to personal protective equipment. Many communities, many companies don't know that they're required to have a personal protective equipment assessment completed for all job tasks. So what does that involve? Well, typically, what most companies do is they select a given form that is to be used to assess. Once the form has been decided upon, the forms are sent out to the department managers so that the department managers can then do a hazard assessment specific to personal protective equipment on each task. It's a one-time assessment that is then updated if necessary, if new jobs are brought into the work environment or if any changes occur to the job task. But many communities, many companies did not have those PPE hazard assessments completed the way that OSHA wanted them completed, and we started seeing some citations in that area as well. Lastly, the general duty clause is a catch-all for pretty much any safety-related item that OSHA feels you should have in place that they don't have a standard for. So it generally states you must provide a safe work environment, and they can capture violence in the workplace issues, They can capture combative resident issues, slip and fall issues, and resident handling and transfer issues. All of those items can fall under the general duty clause because there's not a standard associated with them. I'm now going to turn it over, back over to Cullen to discuss the record keeping of COVID-related cases.
Okay, thanks, John. So when it comes to the recordability of COVID-19 cases on your OSHA 300 logs, fortunately, OSHA has provided us with very clear guidance. So let's review that guidance and hopefully clarify for you whether some cases should be recorded or reassure some decisions that you've already made in terms of record keeping. The OSHA guidance says that employers are only responsible for recording cases of COVID-19 if all of the following are true. And there are three things here. Number one, the case is a confirmed case of COVID-19, so we have to have a positive test. Number two, the case is work-related as defined under the record-keeping standard, which is 1904.5, excuse me. And number three, the case involves one or more of the general recording criteria set forth in the record-keeping standard, which are medical treatment beyond first aid, days away from work or restricted duty, loss of consciousness, or a fatality. Unfortunately, determining item number two, which is work-relatedness, is proving to be very challenging for employers in many cases. Looking at the OSHA definition of work-relatedness, it says it's work-related if an event or exposure in the work environment either caused or contributed to the resulting condition or significantly aggravated a pre-existing injury or illness. Work-relatedness is presumed for injuries and illnesses resulting from events or exposures occurring in the work environment. What OSHA is looking for employers to determine is if there's objective evidence that a COVID case may be work-related, and if that evidence was reasonably available to you as the employer. Considering this, it's very important that you conduct thorough investigations to determine work-relatedness of COVID cases you're made aware of. And I would suggest in any case you're made aware of COVID, you really should take the time to investigate and document. OSHA has specifically advised on three things to include in your investigation. First, that you ask the infected employee how they believe they contracted COVID-19. Next, while respecting employee privacy, you may discuss at-work and out-of-work activities that may have led to the illness. So you can contact trace within your organization to the best of your ability. Try to determine if close contact may have occurred outside of work with family members or anyone who lives with the employee, and consider if the employee works at another location somewhere and could have contracted it there. And finally, review the work environment for any potential exposures that have occurred. Use all of this information to try to establish a timeline of events as related to the onset of symptoms or a positive test result to confirm or reject work-relatedness. Regarding any work-related COVID inpatient hospitalizations and fatalities, you need to take a very close look at the timing of these events. And here are the reporting requirements for hospitalizations and fatalities. And please note, these are unchanged from normal circumstances pre-pandemic. These requirements have been in place for a while and they are the same today. First, fatalities must be reported within 8 hours, and only fatalities occurring within 30 days of the work-related incident must be reported. So if the death takes place 35 days after the last exposure, that's not something you would have to report to OSHA. And inpatient hospitalizations must be reported within 24 hours, and only hospitalizations occurring within 24 hours of the work-related incident must be reported. Please take note, OSHA has said that for cases of COVID-19, the term incident means an exposure to COVID in the workplace. Therefore, in order to be reportable, an inpatient hospitalization due to COVID-19 must occur within 24 hours of the last exposure or potential exposure to COVID at work. The CDC continues to report the incubation period for COVID from time of exposure to symptoms appearing is 2 days or more. So considering this, if your investigation can reasonably establish an objective timeline of when the exposure may have last occurred at work, I think it really helps reduce the chances of you needing to report hospitalizations to OSHA. Okay, with that, let me hand it back over to John, and he's going to discuss an overview of OSHA record keeping and reporting.
Okay, so what's the difference between record keeping and reporting? Well, record keeping is the keeping of your OSHA 300 and 300A forms. Reporting is your requirement to actually reach out to OSHA under certain circumstances. Under record keeping requirements, we're going to go onto OSHA's webpage in just a minute and take a look at how OSHA defines a recordable injury or illness. And part of that is how OSHA defines first aid, because in many cases, clients of ours have previously, before we started working with them, they have been reporting cases where they did not have to. They didn't realize how OSHA defined first aid, and anytime they were sending somebody to be treated, they considered that medical treatment and would automatically put it on the OSHA 300. What that does is it raises the DART rate, which is the incident rate, and that can prematurely prompt an OSHA investigation. So the definition of first aid is extremely important. We're going to take a look at those items in a minute. From a maintaining and posting records standpoint, I'm going to walk you through the 300 and the 300A forms to make sure that you understand how to fill those out. And then we're going to get into electronic submission of records. A new requirement as of a couple of years ago requires employers to report the 300A prior to March 2nd of each year online with OSHA. And many employers still don't even realize that that is a necessary component of reporting, of record keeping. And lastly, we'll talk about the severe injury reporting and walk you through that. So right now, what I'm going to do is stop sharing. You're going to see your screen disappear. And then you are going to see OSHA's webpage pop up, just so you know that there's not a technical difficulty going on here. All right, so you should see the OSHA injury and illness record keeping and reporting requirements page in front of you. We are going to include this link when we send out resources to you. I would strongly suggest that you share this link with whoever is in charge of filling out your OSHA 300 and 300A or doing any type of OSHA reporting, because this is the go-to page. You want to be able to come back to this page. So we're going to navigate this page starting off with how does OSHA define a recordable injury or illness? And you can see a drop down with a number of bullets here. Obviously, a work-related fatality would be a recordable injury. But in addition to that, injury or illnesses that result in the loss of consciousness, days away from work, restricted work, or transfer to another job would be recordable. Now, where it gets a little bit dicey is the third bulleted item, where it says any work-related injury or illness requiring medical treatment beyond first aid. Most feel when they send somebody to see a doctor that they are receiving medical treatment. However, that's not necessarily the case. We're going to back out of this, take a look at the next bulleted item, which says, how do we define first aid? And you can see a number of bullets here that discuss what OSHA considers first aid. Now, I will use number 2 as an example as to why this can be confusing. Most people would think that a tetanus shot, somebody steps on a nail and they go to a doctor and receive a tetanus shot. Most people view that as medical treatment. OSHA does not. So if you have somebody who goes to seek treatment and all they receive is a tetanus shot and they're sent back to work, that does not have to go on your OSHA log. If you look down at the, forget which one it is here, I think it's the third or fourth one, they talk about drilling of a fingernail, which also to me seems like medical treatment, but again, it's not. So it's important that you take a look at this list, and if nothing else, maybe print it out or bookmark it so that when somebody goes to seek treatment, you can cross-reference the treatment with this first aid case. And if it's not on the first aid list, then it is indeed medical treatment. One example to give you, if that happens frequently, if somebody is cut and they go to seek medical treatment, stitches would be considered medical treatment, but just putting a Band-Aid or a butterfly bandage on it would not be considered medical treatment. Now, sometimes there are interpretations that come up, and in relation to the cuts, they now interpret the medical glue as stitches. So that would, again, be considered an incident that goes on the on the OSHA 300 as a result of medical treatment. So let's scroll down and take a look at our OSHA 300 form. And you should see the screen change a couple times. And hopefully, here we go. Took a little while there. Sorry about that. We're going to scroll down to where the OSHA log is, and I don't expect you to be able to read this. But what I'd like to do is at least talk you through it. So your OSHA log should look something like that. And if we go left to right, the simple columns to fill out are the case number, the employee name, the job title, date of the injury, where the injury occurred, a description of the injury, and then we get to this gray area that has 4 different columns. This is where it gets a little bit more difficult and where a lot of errors are made. If you were able to read the very top of that column, it asks you only to check one of the 4 drop-down columns in the gray area. You're checking the most severe of occurrences. So you start going left to right. The first column asks if it was a death. If it's not a death, then you go to the days away from work column. If the incident involved days away from work, you will check the days away from work column, which is column H. You do not check any other column. Okay, what happens, and the mistake that a lot of individuals make is, let's say an incident occurred involved days away from work, and then involved job transfer or restriction. In many cases, we will see new clients of ours check both of those columns. And what ends up happening is that is logging 2 incidents rather than 1 incident on the OSHA log. So you only check off the most severe column going left to right. However, if we go further to the right on the OSHA log, you will see that it asks for the number of days away from work and the number of days for transfer or restriction. You are able to put the number of days in those 2 columns. The problem is people end up checking off more than one of those gray box drop downs. So that's the important part. When you go to check off a COVID-related case, on the far right-hand side, you will see a number of descriptions of types of cases. The first one is injury. So most incidents that go on the OSHA log fall within the injury column, and you will check off injury. However, COVID, you are checking off the respiratory illness column. All right, let's scroll down. One thing to note on this, if you use OSHA's website and you fill out the OSHA 300 form, as you're seeing it here, it automatically populates your 300A for you. So that's something you may want to consider if you're not already doing so. So all the columns, all the items on the left side of this page should be automatically populated from the data that you entered in your 300. The mistakes start happening on the right-hand side of the 300A page. So if you, I don't know if you can read it or not, but it does ask you for the total hours worked by all of your employees. It's important to realize that the hours should not only be your employees, but they also need to be any employees who work under your supervision. So if you have agency working within your building, the agency hours should also show up on the total hours worked. At the same time, those agency employees, if injured and if the injuries are recordable, should go on your OSHA log, not the agency's OSHA log. So that's a big one that is often missed and cited upon. And lastly, on the 300A, at the bottom of the page, you will see an area where a company executive is to sign this. That is the top ranking individual at the site. In many cases, Human Resources fills out the OSHA 300 and the 300A, and they end up signing it at the bottom. They also get cited for that. So just make sure that the highest ranking individual signs the 300A. When does the 300A then get posted? It needs to be posted within the building for employees to see from February 1st through the end of April. Now we are going to backtrack, and we should see the main page that we were on. Okay, so now we're going to go to where it says electronic submission of records. So as I stated a couple of years ago, maybe 3 years ago, OSHA decided that they would now require employers to report the 300A on their page. So there is a link here that says ITA launch page. If you haven't already done so, you would click that and you would come to the page, and on the right-hand side, you see a big red rectangle that tells you can launch that page. Once you launch it, it will ask you for your information, it will ask you for a password, and you establish an account. You then will manually enter the 300A information into OSHA's system. When does that have to be done? It has to be done prior to March 2nd of every year. And I will tell you that you should go ahead and enter that information about a month in advance. Many of our clients tried to do it within the last week prior to March 2nd, and OSHA's system couldn't handle it. So it really, many of them weren't able to input the information until the second week of March. Let's backtrack and take a look at the last item here, which is the severe injury reporting. And Cullen went through a number of these items, but let's talk about them once again because there's a lot of confusion with these. So prior to the change, I would say maybe 6-7 years ago, OSHA only required the reporting of a fatality or incidents involving 3 or more individuals who are hospitalized. They decided to change that. Now, all employers are required to notify OSHA when an employee is killed on the job or suffers a work-related hospitalization, amputation, or loss of an eye. So the fatalities must be either called in or submitted on OSHA's website within 8 hours of the fatality. As Cullen mentioned, the fatality, in order for it to be reported, has to occur within 30 days of the occurrence or onset of symptoms of COVID. Okay, so let's talk about the inpatient hospitalization. It's not just going to the hospital, it's being admitted to the hospital within 24 hours of an occurrence or onset of symptoms. So in most cases with COVID, the hospitalizations do not have to be or have not had to be called in because they are occurring 3 to 4 days following the onset of the symptoms. The amputation or loss of an eye also have to be reported to OSHA within 24 hours. All right, I am going to back out of this, stop sharing, and get us back to our PowerPoint. And I think now what we are going to do is field some questions. Rafael, I'll turn it over to you.
Thanks, John. Appreciate it. We did get one question from Pat Pierce. Per the recordability information, if an employee is confirmed COVID and got it from a coworker, but doesn't need medical treatment and works remote from home with no lost time, they do not need to be recorded. Is that correct?
That is correct. And that is...
Sorry, go ahead, John.
Oh, no, you can go. You go, Colin.
Yeah, no hospitalization, no medical treatment beyond first aid, no lost time, no restriction of duty. That is correct. They do not need to record that.
So what do you do when you're at the organization and OSHA shows up at your front door, John? What's the first couple steps that we're doing other than calling you guys to make sure you can handle it for us?
Well, that was the first one. We always encourage our clients to call us because we like to be able to obviously participate in an OSHA inspection if one takes place. But number one, don't panic. Be friendly. Only provide the information that's requested. You will first be requested the OSHA. They'll ask for the OSHA 300 and 300A information. They'll probably go back 3 to 5 years. We typically see 3, but sometimes up to 5 years. Based upon what they see on the OSHA 300 or 300A, they will request more information. Know that if you are a union site, that you are required to offer a union representative to be part of the OSHA inspection. But I think the main thing is try to keep OSHA to an area that does not allow them necessarily to see your entire organization at one shot, if you can do that. They will in most cases asked to do a tour, and at that point in time, you will have to take them around. They will ask to speak with a number of employees, which is why it's extremely important to be honest and forthright with them, because if you're not, you're just going to get yourself caught up in a string of lies as your employees start to tell how it is. So you really need to be 100% honest, and they will allow you to select typically the employees that are spoken to. Try to select an employee who's a straight shooter, who's not going to complain a lot, but it will also tell it like it is.
So there've been a couple times where we've been pulled in a little late to the game. So the question then comes from the client, if the organization receives citations and fines already, do we just pay them? Do we fight them? What do we do in that situation?
Okay, so most companies, if they've never been through an OSHA visit, if they see small fines, they typically just want to pay them and get rid of OSHA. We don't encourage that approach. What we'd rather do is set up what's called an informal conference, where we sit down with OSHA face to face, and we not only can take a look at the citations that were delivered and explain what we've done to abate those citations, but we also want to let them know all the good things that we're doing. We want to put a good foot forward and develop a relationship, because it's probably not going to be the last time that we see OSHA at our doorstep. So if we just pay a $5,000 fine because we don't feel like dealing with it, that pretty much says we're just trying to get rid of OSHA. I think it's a better approach to take the 2 or 3 hours, go visit your local OSHA office, put your best foot forward, and develop a relationship. And hopefully, the one thing I didn't mention is if you have the ability to reduce those fines even after you have that informal discussion. So you have the discussion, you let them know what you've done to make improvements, and then they will ask you to talk about the fine itself. You typically can negotiate down about 30%, right in that range. So in some cases, you can get the fine down. In some cases, you can combine certain citations into one so that they don't show up as multiples on OSHA's website, because OSHA's information is public information. And if somebody searches your organization, you really want to have as few citations showing up as possible. So you can negotiate the dollar amount. You can also in some cases negotiate combining some of those citations.
All right, thank you.
Sure.
Cullen, question for you. What do we do if someone can't pass the respirator fit test?
Right, yeah, so that can get a little bit difficult. The first thing that I would suggest is have a variety of different kind of styles and brands of N95s available and multiple sizes. That, if they can't pass initially, just try some different options. But ultimately, if somebody cannot pass the test, they should not be allowed to be in a job where the use of a N95 becomes mandatory. For anybody in your organization who is not able to pass, I would also look at shaving. They should be clean shaven. If they're not, that can impact, and it does impact, the ability to pass a fit test. So also look at that as well.
So no more coronavirus beards. Those don't help much anymore.
Correct.
Okay, got
Yep.
it. Final question for
off.
you. Yeah. Final question for you, Cullen. Who's allowed to conduct the training for the use of those respirators?
So OSHA doesn't really make this crystal clear for us. They say something along the lines of someone appropriately trained or experienced with complexities of respiratory protection programs, and that's it. So it's very vague. So people like John and myself, we're qualified. We would be ideal, and in fact, we've been able to do this for some of our clients throughout the pandemic. So what I would suggest is, if you don't have somebody in-house, check with your insurance broker or your insurance carrier to see if they could assist. In many cases, you could do what's called a train-the-trainer type solution, where they would educate you, and then you are now familiar with the requirements of the program, and then you can continue to train in-house.
Okay. We got a question from Nathan Hughes. It said, what if we have an employee that is still experiencing long-term loss of taste due to COVID and cannot taste the testing solution?
That is a very good question. And what happens is they can't pass that test, right? So we don't know if they're susceptible, to the respirator not fitting because they can't taste it. To me, that's a failure. So until that person is able to regain taste, I don't think we can pass them and put them in a respirator.
There is one. I've not done this with any clients, but there is one option in regards to that. OSHA allows what they call qualitative and quantitative fit testing. Most of what our communities are doing would be considered qualitative fit testing, where they've got the hood, the Bittrex or the saccharin. However, quantitative can be done using a device that punctures through the N95. It destroys the N95, so you wouldn't be able to reuse it. I've not done it, but I know that companies that act as a third party that do quantitative fit testing have that capability. So I would reach out to a vendor to see of those who do that, if they'd be able to fit test that one individual using the particular type and size of N95 that you have on site.
Thank you. We have a good question. If you had an employee die of COVID a year ago and unsure if we filed, what should we do now besides check if we filed?
That's a tough one. I guess the question, some clarification on that question, were we or have we been considering COVID exposure a potential recordability case, or are we just now finding out about that? Meaning, did we know about it and not do it, or are we finding out now and deciding whether to go back?
Why don't we play out both scenarios?
Okay. We've had one or two clients who decided from the start that they didn't feel there was enough evidence under any circumstance to decide whether or not OSHA should know about their COVID-related cases. So we've had some clients that have not reported any, and then we have others that have reported upwards of 100. One of those that reported none of them just got an OSHA visit as a result of a fatality. And they asked me the exact same question. Should I go back and record all the ones that we previously had, or how should we move forward? And I think they should stick with their original approach. If they don't feel that it was recordable, then no, they shouldn't go back and put them on there. Should they have from the start? I think they should have. My personal feeling is they should have, but I don't think going back is going to really help any circumstance. So I think if you made a mistake in the past, you've made that mistake. Let's just move forward doing the right thing based upon what we talked about today.
Okay, thank you very much. I think that exhausts all the questions that we've had in the chat, unless anybody else wants to quickly type another question in there. No, and I guess not. So John and Cullen, we want to thank you very much for joining us today and conducting this session. I will say personally that, in talking with our clients, John, Cullen, and the rest of the loss control safety team at JKJ are game changers when it comes to making sure that our clients are as protected as possible. But then when bad things do happen, which they will, you're as defensible as possible, and you have all of your ducks in a row so that you can present yourself in the best light to OSHA and the other litigants that are coming at you. So thank you again to John and Cullen for joining us today. And I'm going to toss it back to Emily, if that's all right.
Sure, absolutely. So thank you everybody for tuning in today. And you will receive a follow-up email from me, Emily Gross at Lutheran Services in America, containing materials from this session, including the full recording, the PowerPoint, and additional resources from JKJ. And this presentation is part of our Strength and Service series, which will be continuing throughout 2021. Our next webinar is called Preserving the Not-for-Profit Legacy in Senior Living, and it will take place from 1 to 2 p.m. on Wednesday, May 12th. So more information about that will also be sent out via email, and Thank you so much again for joining us, and thank you, Raf and Cullen and John. So
Thank you,
we'll,
Emily.
yeah, we'll go ahead and adjourn. Everybody have a great day.
Thanks all. Take care.